chain. So I'm going to show you a few new diseases which has come to the forefront, which we have worked together with geneticists and other clinicians. So I'm going to discuss a bit about discoveries in the last 5 years. So this is not even previous years. I'm just talking about last 5 years, which has really contributed to the genetic landscape in South Africa and identification of inborn errors of metabolism. So I'm going to speak about pyridoxine-dependent epilepsy, a case study on that. I'm going to discuss the lysosomal storage disorders and the platform we currently are using to diagnose these disorders. I'm actually going to discuss hyperphenylalaninemia, which is I think most of the clinicians, you may have seen a case study of PKU in your training. So I thought this is a good connection point, and I'm going to give you some new information on that. And then I'm going to give you on cerebral creatine deficiency syndrome some information, and I'm then going to just have a take-home message. So going straight to the first disorder is pyridoxine-dependent epilepsy, and this is due to alpha aminoadipic semialdehyde dehydrogenase deficiency, and it's due to a biallelic pathogenic variant in the ALDH7A1 gene, and it's got quite a high incidence with 1 in 100,000. And again, these patients present with epileptic encephalopathy. So in the neonatal early infancy period, I've heard of some cases that just as they come out, as they're being born, they have epileptic onset. So 75% of the patients on pyridoxine still on pyridoxine still have intellectual disability and development deficit. So there's been a lot of work put in looking in further treatment options for these patients. And currently we cannot offer functional testing in South Africa, but we are working on it. So this is just the metabolism, and I know this is daunting to you, but I just need to show you, because Surieta spoke about the lysine catabolism, where glutaric aciduria type 1 lies, but there can also be the pyridoxine-dependent epilepsy can be induced by AASA dehydrogenase deficiency, which results in the accumulation of AASA as well as 1-piperidine 6 carboxylate. Fortunately, these are not very stable. You can sometimes see in some patients pipocolic acid, and we have potentially now identified a new metabolite via metabolomics approach. And there has been subsequent publication on more stable metabolites that we can use to diagnose these patients. And the accumulation of this immobilizes the production of the functional cofactor pyridoxal 5-phosphate. So I'm just going to show you a patient that was referred to us, very young patient. The clinician phoned us. He said, encephalopathy, unexplained, no reason why it is there. It's rapid. The patient presented with rapid breathing at 18 after birth with respiratory alkalosis, and our initial thought was that this was perhaps a urocycle disorder. That's what the clinician thought of, and the lab could not. They're very remote, so they could not measure ammonia. So we arranged. Then the rest of the routine chemistry were normal, and then all of a sudden, all the routine metabolic testing came back normal. And still, he said that this patient has pharmacoresistant epilepsy. And I think this kind of prompts the simultaneous epilepsy panel, gene panel testing, where pathogenic variants in the ALDH7A1 gene was identified. And strange, or not strange enough, this is known that in the neonatal period or in the early infancy period, if you do give these patients pyridoxine, they can develop apnea, and you then need to stabilize them again and extend after, and resuscitation may be required. So the doctor actually gave pyridoxine and was very shocked because this baby decompensated in front of him, but it was just a natural response. And then when pyridoxine was established again as treatment option, the patient stabilized. And unfortunately, follow up with this patient still showed developmental delays, the disease is still progressive as described in literature. So we so far have been involved in 3 patients which have been diagnosed, and I suspect the geneticists have more in South Africa. And then 1 patient has been recently diagnosed via the Nngwe approach. So I'm just going to show you this picture because I think it's appreciated by the clinicians that's attending. So it's persistent fitting that you see, and it's pharmacoresistant. So if you do have a patient with encephalopathy, your blood work comes out normal, your routine metabolic testing comes out normal, the epilepsy is pharmacoresistant, then please consider then a pyridoxine-dependent epilepsy. And pyridoxine can then, its vitamin B6 can be given, and just take note of what can happen after it. And so I just want to reiterate that these and the variance that was described in this patient compared to a mixed race patient that we recently diagnosed is different. So it doesn't seem to be just Caucasian. It seems to be like they may be not just not Caucasian, but also in the mixed race population. So I'm just going to, the treatment first line is pyridoxine, but as you heard, it's not very effective. Lysine restriction, actually, this is a good thing because we have formula for glutaric aciduria type 1 in South Africa. So we have formula for AASA deficiency in South Africa. So we can actually use this in these patients. We combined it with L-arginine, and then the integrated approach has shown improvement in motor skills and seizure control, but more studies is needed. And then there's actually a new study that just came out in 2022 where they look in inducing in the initial step of the lysine degradation pathway a defect, and that will prevent the production of ASA as well as glutaryl-CoA, and treatment for both of these conditions. So this is a very, very good YouTube movie which you can actually look on more on it. This is the paper of the consensus guidelines. So we're going to move over to the lysosomal storage disorder. Historically, we know that we test for it. We have a qualitative diagnosis of MPS, which we can use to diagnose MPS and oligosaccharides, and then sponsored testing was offered when ERT replacement became available in South Africa. And then it was recognized that we need to centralize all data and enhance testing capacity, not that all the samples need to go out of the country. And for this reason, funding was provided for us, and we set up the validated platform in mid-2019. This was a big step forward because now you're in the same country, you can have a consultation, even if you're in the private or state sector. A DBS kit can be delivered to you where you are, or arranged via Path Group. Advised on test selection can now be done also via us or via the group George or Surieta, and we can compare results with other metabolic tests that has been performed, and additional test recommendations based on the phenotype can also be given in the report. So it was a big plus. Till date, 5 years, we have received 3,274. And when I saw this and I saw that we have signed out so many reports, I actually became tired, but also excited. So we have 4% of these cases was positive cases, which is a 1 in 25 cases tested positive, which is extremely high for a rare disorder. But what is very important, so this is how the dried blood spot looks. You need to fill in all the information, and you need to click the specific condition you need to test for. Because if you click all, or if you click none, we do not know what exactly to look for. Also look at the expiry date of the card. And here I just said that click one, the one that is most relevant for the clinical presentation. And also note your collection, that it's not oversaturated or overlaid. So how many cases did we have? We have 137 positive cases in 5 years, which is extremely high. So about a handful of cases in this cohort was already established patients, and this is mostly in your Gaucher cohort. And I can confirm that the 1448 mutation is still the most prevalent in combination with other mutations, and it's right through to infantile onset to late onset adulthood. So we see the whole spectrum of type 1, 2, and 3 here. Second most is MPS 2. Very interesting. It's an X-linked disorder, so only males present with it, and the mutations are all over the place. There's no common mutation in South Africa. It's just all over the place. We note when a new case comes up, we note a novel mutation again. It's maybe not novel in literature, but it's novel within a South African perspective. So these patients are the most, mostly a Black population, but we also have a large white population cohort. And so it affects, all population groups in our country. Second is Fabry disease. And I think a lot of awareness has been created around Fabry disease because these patients can present later on in life and be diagnosed when they first have a certain systemic involvement. And I will urge you to attend our CPD lecture series on Fabry disease, which is in the following 2 months, and where it will be intensely discussed. So I'm not going further into this. 11 Pompe cases we've diagnosed, infantile Pompe as well. And infantile Pompe, unfortunately, we could not get the patients early enough on enzyme replacement therapy. So we have, for example, one clinician that he never wants to miss an infantile Pompe disease patient, and with all his newborn screenings, he refers a LSD panel as well, because he feels that it could save a life. And indeed, it can be infantile onset Pompe. I just also have to elaborate on the phenotypic overlap between Niemann-Pick AB and Gaucher disease. So some may think that it's Gaucher disease, but it's actually Niemann-Pick AB. And 4 of these 10 patients is adult onset, with the rest early onset progressive disease. So also a lot of MPS 1s we've identified. So they are out there, and to have 137 cases in 5 years, I think is extraordinary. So I'm not going to go into the optimal blood spot collection, but please always use a finger or heel prick. Do not use an EDTA blood to spot, because this influences the analytical platform that we use to measure the enzyme activity. Storage and shipping, humidity, coastal areas. The humidity is problematic in the coastal areas, and you will get a result sometimes back, which is demoralizing, that this is an artifact because there's 2 or more enzymes low. Unfortunately, that's why we put in the desiccant in the little plastic bag, but we still get this artifact. So we have to get the sample as soon as possible to the lab, because the enzyme stability is dependable and is influenced by temperature and humidity. So now I'm going over to hyperphenylalanemia. Actually, some of you know about classical phenylketonuria, PKU, but today, I don't know how many of you know, but there's actually 8 genes that are associated with hyperphenylalanemia. So that is what we call the group collectively, and classical phenylketonuria due to a biallelic mutation, pathogenic mutation in the PAH gene, results in PKU, and we've seen it mostly in Caucasian population in South Africa. Not as prevalent as the organic aciduria or urocycle disorders, but that was illustrated by George and Surieta. But we have, through the newborn screening panel, we have made a difference in 3 patients' life. And exactly last year, we diagnosed 2. So you can pick them. Yeah, newborn screening is again very relevant here. So historical cases showed that PKU in SA has a slow progressive neurological decline, which is irreversible. And they have these features of light complexion, unexplained developmental delay, behavioral problems, and autistic spectrum features. So Black patients with HP has been identified. And these patients actually present a little bit differently. So they have a severe neurological phenotype, more in keeping with a neurotransmitter-like disorder. So we never knew. We knew it was probably not PKU, but it was definitely maybe one of the cofactor biopterin deficiencies, but we never knew. And I think maybe George, they've seen many more Black patients, but we have seen 5 cases, and we have not been able to elucidate the genotype because of funding, and it's not these families do not have funding because the PKU formula is so expensive. So they just give their patients the PKU formula. So I'm just going to show you what the difference is. So if we have in the PAH enzyme deficiency, you will see that these metabolites accumulate, and they are toxic and give the neurological presentation, slow progressive developmental delay. But if you have a cofactor deficiency, which is also responsible for the breakdown of tyrosine and the breakdown of tryptophan, then you have a deficiency in dopamine and serotonin, as well as the accumulation of these metabolites, which is also toxic. So this is probably why we are seeing a more severe, or it is why we are seeing a more severe phenotype. So I'm going to show you a case now. At infancy, the male had normal development until the age of 8 months. Seizures started, developmental delay. There were axial hypertonia and spasticity. So it's not PKU-ish. The MRI showed that it was compatible with a previous hypoxic brain injury, and they were definitely, the EEG was abnormal. So at age 6, when the patient was followed up again, progressive developmental delay. The patient now has spastic quadriplegia, global developmental delay, limited verbal skills, cortical vision and hearing loss, and the seizures continue, and now also have the dysmorphic features of, for example, the scaphocephalic head shape. So here you can see the biochemical testing when he was 3 years old. So in 2020, he was tested first. I think this was done at the NHLS. After this, put on a PKU limited diet or PKU diet. And then we again tested the patient when he entered the Nngwe project. And there wasn't a great drop in phenylalanine levels. And through the Nngwe initiative, we could finally elucidate on the genotype, which is in the QDPR gene, and it results in dihydropterin reductase deficiency. And it was a homozygous null variant, which resulted in a premature truncated protein. And the treatment of this current patient was valproate, baclofen, multivitamins, and then the strict PKU diet. Attends physiotherapy, symptomatic management via a care dependency grant. The patient has not gained any further milestones, even though this has occurred. And the initial lack of the genetic cause due to access to specialized care and supplementation as advised in the literature resulted in a suboptimal medical management of the patient. And this actually happened because etiologies that was initially considered was cerebral palsy due to hypoxic brain injury, which was initially seen on the MRI, or an infectious disease affecting the nervous system. So the focus was on this and not on a rare genetic cause. And I again want to emphasize that if this patient was newborn screened, we would have picked it up, and early intervention would have perhaps made a difference, and we may perhaps have found a way to do genetic testing for this patient, and not at the age of 6 or 3 years diagnose the patient finally with dihydropterine reductase deficiency. So we suspect that the other patients do have the same deficiency, but one of the other 8 genes resulting in hyperphenylalaninemia may also be involved. So it's not a done deal. We are working on a second case now.
Wrap up. We're going a little bit
over. Okay, I'm wrapping up. So I'm just going to tell you about the GUMP deficiency, which is in the creatine anabolic pathway, and it's a very treatable disorder. We had an 18-month-old female, history of seizures, mild global developmental delay, feeding difficulties, mild hypotonia, and then subtle dysmorphic features. A WES at the international lab was done. The variant was identified in the GUMP gene, but the geneticist that was involved said that this disorder is typically presenting at the age of 3 years, but now we have an 18-month-old presenting with these. And a homozygous missense mutation was identified and later on defined as pathogenic. So functional analysis was required in this young patient, which is not available in South Africa. And we offered on our research platform GAA monitoring, but the drawbacks is that anticonvulsants interfered with this analysis, and we discontinued that, and we're busy setting up an LC-MS method. And the next step is now to send it to have a parallel validation with the international lab. So the take-home message is WES panel testing has opened a Pandora's box of novel variants. Collaboration between medical specialists and laboratory services is imperative. Recognition of certain symptoms and specific tests has improved considerably in the medical community. Sponsor testing has resulted in defining the lysosomal storage disease landscape, and we can also monitor it via metabolite analysis here. Treatment options is available. CHM Rare Diseases Biobank has played a big role in collecting these cohorts of patients, and the Rare Disease Society has been on the forefront of advocating for diagnostic services, providing counseling, and motivating for treatment access. And I just want to thank you. These were the clinicians involved in the case studies. I first want to thank you, the families who persevered in the diagnosis for their child. And then a thank you to all the clinicians who have referred for the lysosomal storage disorder. We have defined the LSD landscape, the Rare Disease Biobank, and the CHM staff who have been committed to live our motto, One Life Matters. Apologies for going over time.
Thank you so much, Marli. You had some big words there, and we are inspired by the work that you do. And I think that's now such a good time to hand over back to Prof. Chris Vorster, who will now tell us, how do we go when we are out of options? Who do we contact? Who can we speak to? And how can we really get this collaboration between the labs and the clinicians so that we can diagnose more patients with these rare inherited metabolic diseases? So back over to you, Chris. And this is a 90-minute webinar, so please hang tight because we've got some good questions that we still need to answer. Thank you, Chris.
Thank you. Did I share the right screen?
Yes.
Okay, great. I don't know if I've got all the answers, but I'm going to present to you a proposal that I think could work going forward. Okay, so I thought I'd start off with a case study, but I'm doing it in the way in which we encounter it in the lab. So we start with the variants and we work our way back to the patient, which is sometimes the case if you don't have all the clinical information and so on. And if at some stage you wonder, why am I presenting this to you, then just hold on. This particular case actually demonstrates very nicely why we need what we need. So let's get going with this. So I'm presenting 2 variants. One is from a WES case and one is from literature. And I'm not going to go into detail on the way in which we name these variants, but I think it would be sufficient to say that these are variants in a gene called SEL. In one patient in the cDNA in position 2007, there's a duplication that shortly afterwards results in premature truncation of the protein. And henceforth, I'm going to call this one V670. And then here's a second patient. Note, this patient is heterozygous, right? And then there's a second patient here who has a deletion in 147 and 148. And then around about 50 amino acids later also results in premature truncation of the protein. And this patient is homozygous, and henceforth I'm going to call this patient F50. Okay, so when I first saw this, I had no idea what SEL is, but it was quite easy to just check that the protein product of SEL is carboxyl ester lipase. And now the question is, are both pathogenic? Is it just one? Which one? Or are both benign? I've shown this case study once before, so if you've seen it, I apologize, but it actually demonstrates very nicely why we need what I'm going to propose. So there are lots of user interfaces these days that one can use that can assist you a lot with variant interpretation. Here I'm using Franklin, which I regard as one of the best. And you can see Franklin has an automated classification using the ACMG criteria. And in this particular instance, it classifies both variants as likely pathogenic based on the idea that this is a null variant. So this is pathogenic very strong, okay? And that the particular variant is present extremely low frequency in reference databases. So if you just apply this criteria as is, which is done very, very automated, very, very quick, you would tend to think that both these variants are likely pathogenic. And then Franklin makes it even easier, so you can quickly check, because I had no idea what kind of diseases is caused by SEL, and it tells you that SEL causes maturity onset diabetes of the young type 8, and gives you lots of clinical information. So onset is in young adult onset, it's an autosomal dominant disease, causes abdominal pain, exocrine pancreatic insufficiency, maturity onset diabetes of the young. And it fitted mostly with our patient's clinical presentation, which was a male, 18 years, recurrent abdominal pain, impaired fasting glycemia, and intermittently raised AST. Okay, so it seems like, you know, everything is in place. So it seems like, you know, we could potentially conclude that both V670 and F50 causes MODY type 8. And F50, because it's homozygous, is probably more affected than V670, which is a heterozygous variant. Okay, so and I think that would be actually be a reasonable conclusion. However, something was odd here. So I do work in a metabolic laboratory, so I'm quite interested in metabolism. And if you think about the function of this gene, which is, or the function of the protein, which is excreted by the pancreas, is the hydrolysis of probably cholesterol and also triglycerides, as I've shown here. And you know, if that is the function, in other words, you are unable to hydrolyze things, then you would actually expect some kind of a fat malabsorption syndrome and perhaps vitamin A deficiency, which doesn't really fit with the clinical presentation described for MODY 8, right, which is a kind of a diabetes and pancreatitis type of presentation. So that for me was a bit of a concern. And then also the inheritance pattern, because, you know, if you work in a metabolic lab with enzyme deficiencies, and you know that most of these enzyme deficiencies will have an autosomal recessive or perhaps X-linked inherited pattern, very, very seldom a autosomal dominant. So that didn't quite add up. And based on that, we thought, okay, perhaps we should look a little bit deeper into this. So now you start to look at the gene and its product, which is the enzyme. So this gene is located on the long arm of chromosome 9. It's a fairly small gene. And like I said, it encodes for carboxyl ester lipase. And so this enzyme is produced by the mammary glands and the pancreas. It was previously called bile salt stimulated lipase, which gives you a bit of a clue of how it works. Major component of pancreatic juice. It's responsible for the hydrolysis of cholesterol esters, as well as a variety of other dietary esters. And it exerts its function in the duodenal juice and is activated when mixed with bile salt. And it's an important role in digestion of fat milk in newborn infants. Now, you'll note that F50 actually occurs in exon 2. So these are the introns and there's the exons, whereas V670 occurs on the very last exon. And there are special rules that applies to variants that are present in the last exon. And that is what I'm showing here. So these are additional guidelines in addition to ACMG. So F50 is predicted to undergo nonsense-mediated decay. And what that just means is if you have these premature truncation, then normally the cell's quality control mechanism will identify the protein as defective and degrade it. So this happens with these null variants, except if the variant is in the very last exon. So there we have to go and look a little bit deeper. So we have to look at, do you have loss of function variants in the general population? And also, is this present in a biological transcript? And then how much percentage of protein is lost? Now, I can tell you that it is present in a biological relevant transcript. It does remove more than 10% of the protein, but what I can't tell you exactly is, is it present in the population? So for this, we turn to NOMAD. And if we look at the spread of data, we notice something very interesting here in exon, in the very last exon, exon 11, is that there's an area where there's almost no data. Okay, so that's something to keep in mind. It also allows us to look at variants that has been reported in ClinVar, and you can see in ClinVar, as filtered by NOMAD in this particular instance, if we just look at the loss of function variants, there's a fair spread of reported loss of function variants, either as likely pathogenic or pathogenic. If we look at NOMAD's own spread, we can actually see a lot of loss of function variants. And then quite peculiarly in exon 11, there seems to be quite a high concentration of loss of function variants. Now, that's not saying it's pathogenic. I know it looks pathogenic here. It's just because loss of function variants are normally pathogenic. But this is just basically what is observed in the population. So I had a look at ClinVar itself. And if you go into the loss of function variants, you see something interesting. Most of them has been in exon 11. There's one that's pathogenic, two that is of likely pathogenic, and then there's some that's conflicting, also one of uncertain significance, and so on. So it doesn't really help to understand the spread of the variants. You can also look at this in Franklin, and if you look in Franklin, you can see loss of function variants has been reported as pathogenic, as uncertain significant, and just one as benign. So based on all of this information, we now have to decide, okay, F50, that really seems pathogenic, but V670, is it pathogenic? It seems like most loss of function variants are pathogenic. However, you'd remember the story that, what I'd expect clinically and the clinical presentation doesn't quite add up. So one of the important criteria with these loss of function variants is that it must be in a disease where loss of function is a known cause of disease. And I started to think, well, is it the case? And so one way in which you can check this is in mice models. And we managed to find a publication of one mice model. And to make a long story short, the conclusion is that the cell Modi phenotype is not reproduced. So a loss of function in cell did not result in the disease. Now, of course, we are not mice, but this does give us quite a strong suggestion that perhaps loss of function in Modi doesn't cause disease. So what now? Okay, so now you start to read, and you 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 read. And after you've done enough reading, then eventually you get to the heart of the matter, which is really this. So Modi 8 is only caused by variants in exon 11. And the reason for that is that there is a variable number of tandem repeats in the gene or in the exon. And that's the area where there's no data because sequences do not, well, most of the sequences used up to now is not all that effective in covering these repeated areas. Then due to a recombination with event with a cell serogene, this is a hotspot for loss of function variants. And the important thing is it's also an O-glycosylation site. So if you have a variant that is proximal to this O-glycosylation site, then there's decreased glycosylation of the protein. And what that does is it increases the stability of the enzyme and also interferes with its release from the pancreas. And the enzyme is cytotoxic, and so it results in endocrine and exocrine dysfunction. And so the conclusion is that the F50 homozygous variant is actually benign, whereas the V670 heterozygous variant is likely pathogenic, which is very counterintuitive than what we know about most variants and so on. So From there, I just want to quickly spring to or jump to rare diseases. So rare disease is a condition that affects less than 1 in 2,000 individuals. There are currently about 7,000 of them, with 250 new ones added annually. Current literature estimates is that the prevalence is around 2 to 6% of the global population. To put that in perspective, HIV in South Africa, 13.5%, and tuberculosis, 1%. So it's more prevalent than tuberculosis. It accounts for around 5 to 20% of hospital admissions. During COVID, rare disease patients had a 3 times increased mortality. So think about who occupies your ventilators. And rare diseases have been neglected with the lack of access to diagnostic services, keeping the gateway to care closed. So I did some quick estimations based on international literature. So, if we have an estimated prevalence of rare diseases in South Africa of 0.5%, it will mean that we have 300,000 patients. And if 2% of them are, if they make up 2% of hospital admissions, then there are 2,000 patients at any time in hospital in South Africa. Even still very low estimate of 2%, we're looking at 1.2 million patients and 4,000 patients in our hospitals. And I wanted to do this, but I did some just quick calculations from our lab stats and extrapolated from that in terms of the number of diseases we can diagnose. And I'm not going to go into all of that, but what I want to tell you is that if I do that, then I come up to an estimate of around about 100,000 patients in South Africa, and that's probably grossly underestimated. So, 300,000 is probably pretty realistic. Okay, so these patients are much more likely to require hospitalization. They're much more likely to be complicated. They require intensive care and life support and consume a disproportionate percentage of healthcare services. So back to the case study. Approach requirements for sequencing interpretation. I'm again not going to go through all of this, but I'd like to point out, know the disease, know the gene product. Okay, and then perhaps also very important is orthogonal confirmation. So if you diagnose a metabolic disease using a panel or WES, please don't step into the trap of leaving it there. Do the necessary metabolic testing. I'll come show you lots of cases where the genetics is positive, even the enzyme analysis is positive, but finally the metabolites shows us that it's actually a serodeficiency. So don't stop just at the genetics. Other conclusions. It may not seem so, but what I can tell you is that variant interpretation is not difficult. In fact, I think, with a fairly intense course, most people can be taught this over a weekend. But it can be extremely time consuming. So you can imagine how long it took me to interpret this one variant. Now, it's not always like that, but it can be very time consuming. It sometimes requires you to upskill yourself to mini expert level, which is what I did in the case of Cell, to be able to gain confidence in the report that you're going to send out. Even so, the risk of errors is substantial. So I've got couple of cases of sequencing done at very prestigious international laboratories, which is the interpretation is simply wrong, and it's just a case of that it's time consuming to do this, and if you've got a lot of cases that needs interpretation, then you're likely to make some errors. Sometimes variant prioritization is ineffective, and we struggle to get to a diagnosis. So we've got some sequencing that was done in South Africa. We still don't have a diagnosis. And if rare diseases makes up 100,000 to 1 million of our population, we're going to have to start to think differently about the way in which we do things, because we cannot service such a population using these techniques. So what is the opportunity? So Diplomics, which is a division of the Department of Science and Innovation, have established the infrastructure that we need. Okay, this infrastructure allows us to diagnose rare diseases in a disease indiscriminate way. So you only need to order one test or maybe two or so. No one institution has the capacity to do this. And this is clinical, analytical, bioinformatics, IT, genetics, metabolomics, proteomics, ethics, biochemistry, etc. However, at a national level, I can tell you now that we've got lots of capacity and possibly even spare capacity. Clinical analytical data sharing will result in rapid analysis, shared variant interpretation, which prevents us reinventing the wheel, optimal management, established focus, expertise based on our findings, opportunities to collaborate, mentor and be mentored, and multiple research opportunities. And the result will be prioritization of rare diseases. It should really be in the top 10 priorities in South Africa, but also specific diseases and specific treatment strategies. So the intent of Nngwe is to provide rare undiagnosed diseases with a diagnosis in the shortest possible time flow using omics, by sharing all clinical and generated omics data. We're conscious of PR ethics and legal. We are sorting that out. Large-scale participation and collaboration to train, to learn, to mentor, and to prioritize rare diseases in South Africa. Think about this differently. Think about it as the square kilometer array in medicine. So what we need is a large collaboration of clinicians and scientists, each with their own interest. Your interest may be in cystic fibrosis, but don't call yourself a cystic fibrosis expert. Call yourself a rare disease expert, because then it's an important health priority. If you're not an expert, if you've got one rare disease patient, then you and the patient's mother is the expert in that condition. So you are all rare disease experts. And then the important thing is share the infrastructure, the data, and the expertise. Now, if we do this, if we have a network of 500 clinicians and scientists, and we start to apply for funding, who's going to refuse that, right? I mean, and the reality is that neither the private nor the public healthcare sector can fund this, but there are other entities that can fund this, but we need to do this on a quasi-research level. And I think it will give you an opportunity to make a difference. So just practically speaking, this is very simplified. I suppose I see the hand's not up just yet. Okay.
You need to wrap up. I've already put the hand up.
Oh, is it? Okay.
Yes, please.
So okay, I'm not going to go through this. What I'm just going to quickly say is that the idea is to provide lots of members with access to clinical data and variant interpretation, while also protecting the interests of particular research groups. So it's all within the research domain still. Maybe later on there will also be a diagnostic arm, but then also those patients that remain undiagnosed, to make them available to the network, who also consists, for example, of bioinformaticians and scientists and so on, that can investigate them and get to a diagnosis, while still protecting the researcher's contribution or the clinician's contribution. Maybe what I can just highlight here is you can refer patients at the moment as part of the demonstration project. However, I don't have ethics at the moment to share the data, which is what I want to do. So at some stage, I'm going to bug you to reconsent the patient so that I can start to share the data. Also, Marty, you promised me 2 people to serve on the advisory board from SAPA, so I'm waiting for those names. And then what should you do is go into the website and sign the pledge. That's the first step. There are currently 84 clinicians and scientists that have signed. After this meeting, perhaps we can be 184. You receive the monthly newsletters. It will tell you exactly what's happening, the training opportunities to contribute. If you'd like to refer a patient, then contact us. In the future, not everything will happen through us, so there'll be lots of independent workings within Nngwe, and then also research opportunities. I need to go back to something very important. This will be set up as a non-profit company, a public benefit organization, and a non-profit organization. So it's purposefully not placed within a university, so that universities don't go and invent their own Nngwe. If you want to be part of Nngwe, you simply become a member. There's going to be a board of directors. You're going to have an opportunity to be selected to the board. And so if you want to fulfill a managerial role or a visionary role and so on, you will have the opportunity to do this. There'll be lots of research opportunities. I'm not going to go into this. The important thing is go into the web, sign the pledge, and then also upload your photo. Marty, you didn't upload your photo, so I'm waiting for you to send me a photo so that we can upload it. And then with that, I'm going to conclude, seeing that I'm over my time, and I'm happy to answer questions later.
Thank you so much, Prof. Vorster. That case study you did that went way above my head, but thank you. We've got people like you who can actually help us put these patients together and understand them further.
Lindu, if you give me a weekend, then you can also do it.
Okay, no problem.
Yes.
We've got next for our questions, we've got Prof. Chris Hendricks, who is passionate about making a difference for rare disease patients. Prof. Hendricks is actually ex-Pretoria chemical pathologist, who is now a medical and a strategic advisor for Rare Disease Cause, which is a non-profit organization that is based in England, which educates clinicians on rare disease management with a special interest in poorly resourced countries. Thank you so much, Prof, for availing yourself, and you are quite well advanced and experienced in the field, and we look forward to interacting with you. We're going to go through the questions on the Q&A section first, and then hopefully maybe we can get through a few in the 5 minutes that we have. So the first question, Prof, is basically from an anonymous attendee who's asking, is exome sequencing available for SCID, which is severe common variable immune deficiency?
Yeah. So, and this actually makes a point, so I'm not an expert in immune deficiency, so we need another expert in immune deficiency syndrome, but there are a number of variants that can cause SCID, and exome sequencing can probably detect most of them, depending on the kind of exome sequencing and the type of variants. Take into account that not everything is point mutations. There may also be structural variants and so on, and not all sequencing techniques can pick those up. I don't know if there are any structural variants in SCIDs. I do know that there are quite a few genes involved. A lot of them is X-linked, and so, but yes, so whole exome sequencing will be able to pick up a large number of those cases. I must also point out that I think one of the path labs has already got a test set up to test for SCID using the I can't remember now exactly what track. Yes, track, using track, which is a method for more of a functional method to pick up these patients. And so where that's available, one should use that. If you do exome and you find or you make a diagnosis of SCID, then perhaps it's useful to also use that functional assay.
Thank you so much.
Thank you.
I think one of the important questions, and we'll probably end the Q&A and go over to the rare diseases. One of the important questions for me, thank you for answering a lot of those questions, Marli, is when is a reducing substance actually useful? Because it is quite cheap for us in government to do. And what does a positive test actually mean? And then just a little bit around GALT. So I think that's quite an important question. I don't know if, Chris, between you and Prof. Hendricks, you can help us with that answer.
Look, GALT is available both through us and through George. So the enzyme assay is widely available. George, I think you guys are doing it on EDTA, right? We're doing it on dried blood spots.
We're doing it on heparin blood. We did it on both and found that we got better results with heparin, whole heparin blood.
Okay.
It's just an issue if these babies have had transfusions, which we find quite a couple of the galactosemics have. And then the best bet is really to go straight for the genetics because of the common mutation when it comes to galactosemia. If you're going to be doing reducing substances, it's just really important to understand that your child has to be on lactose to produce galactose on, that's going to come up positive with the reducing substances. And then one needs thin layer chromatography. And I've seen enough cases where you get a big, a lot of galactose in the urine. But I would say in those scenarios, it's a better approach is to get your baby on lactose-free feed and get a genetic confirmation or an enzymatic confirmation. Because really reducing substances, there are just so many false positives that I think it's wasting time. That's my opinion.
Okay. Thank you so much. I think we must go over to Kelly, and then I would like Prof. Hendricks to just end off the webinar for us with maybe 3 points of wisdom for the pediatrician on how to make the best diagnosis or how to make the diagnosis on some of these rare inherited metabolic diseases. So I'm going to now introduce Kelly. Kelly is the CEO and founder of Rare Diseases South Africa. And she did this when her oldest child was diagnosed with Pompey's disease in 2011 at just 11 months of age. She's dedicated her whole life to fight for those impacted by rare diseases in the developing countries. And she now serves on various boards and committees which focus on improving the quality of life for rare patients. So Kelly, over to you. And I know Kelly is just going to do a really 3 to 5 minute presentation just to advocate for patients with rare diseases. Thank you, Kelly.
Perfect. Thank you so much. Great, really, really great discussions. And I just want to say to all the doctors on the call that feel that this might have gone way over their head, honestly, when you see it all the time and your mind's open to it, you'll be surprised at how many patients you can actually find and identify. From our perspective as a rare disease organization, obviously the advocacy part is one element, and it has been touched on around access to treatments, etc., and how we have assisted. But access to knowing who to speak to is, I think, probably the most imperative thing. So, so many of the questions that have come through have been related to where do we find access to this information, or who do we refer to, or where can a test be done? Those sorts of questions as well. As an organization, if you are stuck, you're more than welcome to ask. And because of the fact that we speak to the likes of the two Chris's, I call them my Chris squares, all the time, and we are in touch with a variety of different labs, we are able to send out like a mass request saying, has anybody got testing available for this? The other really important thing, I think, is to remember that we're working with people. And if people are well supported, it goes on, they do so much better. So if you have patients, and even if you haven't identified what the issue is and they still remain undiagnosed, we are able to support these patients. We run 196 groups online every single day. The SCID patient that was being asked about, we are able to put them in touch with other patients who are going through similar things. And by them being able to engage with the patient and peer-to-peer support groups, they are able to cope so much better because they have better access to information, you have better access to coping mechanisms and skills, and those things really go on to help patients cope on a day-to-day basis, which generally then has improved patient outcomes as well. We do also run a variety of online support and counseling. So we refer to the genetics teams all the time, and I cannot stress the importance of genetic counseling enough. Genetic counseling is honestly a way for patients to really get down and understand what's in front of them in terms of a diagnosis. And it's often done in a way that clinicians often don't have the opportunity to do because of the time constraints, etc. And they're obviously often faced with having to deal with the acute issues that are in front of them. So genetic counseling is imperative, and we're happy to assist patients. We also do run a variety of online and facilitates personal psychosocial support as well. So we do have counselors on board to be able to identify patients who are not coping very, very well and provide them with the necessary support, and obviously refer them to the necessary mental health support, because mental health plays a big part in these genetic and long-term lifelong conditions. Our conditions are not going anywhere. It's a marathon, and no one details where the water points are for us. We kind of have to figure it out as we go. And as a result, having access to that support makes it so much easier. I also just wanted to stress, in terms of being able to connect, we have hundreds. We have, I think, 1,300 healthcare professionals on our database, and we have thousands of patients, and we know these patients on an intimate level. So signs and symptoms become so imperative, and it's so easy for us to group them because we deal with the patients all the time, and we start picking up trends amongst them. And the same goes from a networking perspective. We are able to connect you with other clinicians that are treating a patient that's similar to yours. Even when you're not sure exactly what's happening and haven't necessarily identified or diagnosed that patient yet. So just not necessarily knowing what the problem is, but knowing who to speak to, I think really, really makes a world of difference. And then obviously from an access perspective, once you've identified them and you're now battling, I saw on the chat earlier, there was a discussion around not being able to access to certain testing facilities. We'll come in from an advocacy perspective and do everything we can to change that. We don't get it right 100% of the time, but certainly I think we are making great strides in getting funding mechanisms in place, and between compassionate programs, compassionate testing, programs, research programs, better supporting the patients from a day-to-day perspective, plus our ongoing engagement with funders and government, I think we are setting ourselves up to have a much better system than what we did when my son was diagnosed 13 years ago. And I'm hoping that we can provide your patients with the same level of support. So please do reach out if you have any patients that you feel are needing the support. We are here to help in any way we can. Thank you so much.
Thank you so much, Kaylee. And so that's going to bring us to the end of our webinar. Thank you to everyone that's joined us. I just want to ask Prof. Chris Hendricks, because he has joined us from Philadelphia, if he can maybe share the points of wisdom for a pediatrician that's scared of missing inherited metabolic disease, what they must look out for, and maybe just to end this webinar to just give us a little bit of his wisdom. Thank you so much, everyone, for sticking around, even though we've gone far over time.
I will just...
Chris, are you still around?
Yeah, I would just start off and say congratulations to the team. I just want to say you've got a fantastic team of South African clinicians. So my first piece of advice to pediatricians is don't come to us outside of the country. Speak to the people inside the country, because local variance makes a difference to how disease present. Many textbooks and things are written for European or Western populations. They are not yours. So start with your own people and ask them for advice. That's my first important thing. The other thing is, I think George has said it as well, or Chris Vorster, when a patient is going swimmingly well and something unexpected happens, think about a rare disease, because that's the way that they tend to uncover themselves. You kind of think you're on top of things and suddenly it goes as you unexpected. And usually there's more than one thing wrong. So they unusually single system disorders. So it's usually more than one thing which will get you to think, oh, is there something else going on here? So think about that and do not underutilize your laboratory. Phone a friend, really, really. Pick up that phone. I know you're incredibly busy as a pediatrician, but I do want to say to you, when I started working in the UK, many of my colleagues said to me, I will never see a rare disease patient in my career. And I said to them, well, I can tell you in the UK, the caseload is each pediatrician will have 500 patients per year. And if the incidence is 1 in 17, that's the number of rare disease patients you're going to have in your caseload. And if you're not seeing them, you're missing them. And if you're missing them, speak to somebody else who can help you. Attend the webinars and use the people you have. And then lastly, we can bring perspective for things. And I was fascinated by Marli's presentation, because when she was talking about the hyperphenylalaninemia, my first thought was, this is the HPR, because we've seen that in our African patients that came to England. And we know which mutation they have, and we know actually they do relatively badly on treatment, even if you get them very early on. So, but again, we can bring a little bit of that perspective where we've seen the patients, but do remember local variants again. And another thing that George has said, PD does not work well in our system, but it may work very well in your system. So don't take everything just as the Europeans are always right. Think about what can we do? And remember, the best therapy you have is the one you've got locally available. And don't worry too much if you miss a rare disease, but worry a lot if you don't think about them and try to diagnose them. And that's what I will leave you with.